Hello and thank you for joining me. My name is Jason Twin. Today I'm going to talk to you about acute skin problems, usually infectious skin problems, mostly in children. The purpose of this is to help improve diagnostic skills and for education for medical staff such as medical students, nurses, nurse practitioners and so on. It is not intended as a self-diagnosis tool, so please don't use it as such. So now we've got the disclaimer out of the way. I'm going to divide this talk into two, part 1A and part 1B, just because it's such a big area and there's so many things to cover, and there's probably a finite time you can listen to my voice droning on. So I hope you find these informative. These will form a series of lectures covering different areas of acute GP care. This is my first lecture, so please bear with me. I've found it quite difficult to make this up and to get everything to work as I could do, so it's been quite a steep learning curve, mostly on the IT side for me. So we say it's just a viral rash. Viral rashes in the main these days are very benign. In years gone by, viral rashes made up a host of infections that were frequently fatal to children. The reasons why some of the infections have gone away is mostly immunisation, particularly from measles, but some of the infections are still around. TB, although albeit less commonly. Measles, still around, although it comes in small clusters and unimmunised groups. And scarlet fever is making a comeback, although thankfully it does not seem to have anywhere near the virulence it did 200 years ago. I like this slide. Well, it's obviously not a very cheerful slide, but I do like it because it tells us quite a lot. William Beattie here, obviously not a pauper, but the fact he had a nice gravestone and a burial plot. A builder and wood merchant, so presumably a man of means. He died at 54, which is actually older than the average life expectancy. So it tells us quite a lot. It's obviously not a very cheerful slide, but he had 6 children here, all who died before the age of 2 years. This gravestone comes from Warriston Cemetery in Edinburgh, and if you walk around the cemetery, it's a beautiful cemetery. It's very old and overgrown, but if you walk around that cemetery you'll see many gravestones telling a similar story, so this by no means is a one-off. So the first infection or rash that I'm going to talk to you today about is chickenpox. Most of us have seen chickenpox, I'm sure, so we're going to rush through this really quickly. For the main, chickenpox affects children, young children. It's very infectious. It presents with a fever, coryzal symptoms and a rash. And for the main, it's very benign. There are certain groups in who it's not benign, and we will come to those, but particularly adults, the immunocompromised, and those who are pregnant. So, chickenpox is airborne. It's spread by the virus shedding from the rash and from the discharge from the nose. It becomes infectious 1 to 2 days before the rash, as preceding the rash, usually a patient will become coryzal, maybe feverish, so sneezing, coughing, runny nose, spreading virus here, there and everywhere. It remains contagious until all the lesions have crusted over, and this takes about 6 days. So they're infectious for a total period of about 8 days, and they're itchy, feverish, miserable, and it's very common, so you're sure to see one at some point in your career, almost regardless of what you do. So the course of chickenpox, I'll just pull all the slides up here. It starts off as a macular rash. That means it's a flat red spot, and then it becomes a papule, and we can see a couple of small papules here, so small raised lesions, and then becomes a fluid-filled vesicle like a blister, so that's one of these here. And then if we look over at this side, and then it crusts or scabs over. This is a time often when children pick their lesions because they're itchy, and they often scar at this point. So we're going to talk now about chickenpox in pregnancy. This is one of the groups in whom chickenpox is a serious illness. At any time in the pregnancy, chickenpox is potentially more dangerous to the mother than chickenpox in a non-pregnant mother, because pregnancy is a slightly immunocompromised state, higher levels of steroids floating around, so the risk of particularly pneumonia is increased in a pregnant woman. Infection in pregnant women, of course, can also lead to transmission via the placenta and infectious of the fetus, and this is most dangerous up until 28 weeks, when the child can develop, or the fetus can develop, fetal varicella syndrome, microcephaly, encephalitis, hydrocephaly, so all quite devastating sequelae. I've had a few cases over the years where chickenpox has reactivated. A mother who has previously had chickenpox develops chickenpox in pregnancy, and I'm assured by my obstetric colleagues that this is not likely to be serious, because the mother's antibodies protect the fetus, and so the fetus is not likely to get the sequelae. But if in doubt, then it's always worth discussing with your friendly obstetric colleagues. Chickenpox in adults, again, very serious, particularly if it's a first presentation of chickenpox. It is a myth that people can't get chickenpox more than one. They can. Some people for some reason seem to, and even people who are non-immunocompromised, this can be the case. But inflammation of the lung, pneumonia or pneumonitis is the most common problem that develops in chickenpox in adults. Develops with a dry hacking cough, fevers, progresses to shortness of breath, and can progress quite rapidly to becoming very seriously unwell and needing intubated in ITU, and mortality, even with treatment, can reach 25%. So chickenpox in adults, serious, and not to be taken as lightly perhaps as those in children. So staying with herpes zoster virus, I'm going to talk about shingles. Now shingles occurs in someone who's previously had chickenpox, and once you've had chickenpox, the virus never leaves you. It stays in the nerves, in the nerve cell bodies, and stays there throughout the duration of your life, and every so often it decides to come out and play. Can be years or decades after that it can come out, and for the most part shingles is a self-limiting illness. The actual shingles doesn't do you any harm. The shingles is relatively low infectivity because you don't have the coryzal discharge that you get with chickenpox. Shingles vaccine is now being given to some of our more elderly population in the UK, and this can reduce the risk of shingles by 1.75%, which equates to a 50% relative risk reduction. The main problem with shingles, simple shingles on the body, is post-herpetic neuralgia, and this is the basis for giving acyclovir, is that by reducing the severity of the shingles, if we catch it early enough, we reduce its seriousness and its propensity to cause long-term pain, and this pain can be very difficult to control. It's a neuropathic pain and doesn't often respond well to simple analgesia and can be very distressing. A couple of pictures of shingles. This one's fairly barn door, fairly marked eruption following the line of the dermatome, and this one a little bit vaguer, and they often are quite vague, especially in the early days, and sometimes it's only a couple of spots and then can be accompanied by pain. And there is a syndrome where people get pain along a dermatome and never get any spots. It has a fancy name which escapes me right at the moment, but neuropathic pain along a dermatome, even without the rash, can reasonably be thought to be shingles. Children can get shingles. I think the youngest I've seen a child with shingles is 5. This was an otherwise well immunocompetent child, and so it can occur at any life, but obviously as you get older it becomes more common, as also the older you are, the more likely you are to suffer from post-herpetic neuralgia. So ophthalmic shingles is when the herpes zoster virus reactivates along the line of the ophthalmic branch of the trigeminal nerve. A quick reminder here of the anatomy. It's particular concern because it causes or can cause herpetic ulcers on the cornea, which can cause scarring and damage vision. Pictures here. This one you can see has affected the nasociliary nerve. Now the nasociliary nerve is a branch of the ophthalmic division of the trigeminal nerve, and it supplies the side of the nose next to the eye. This is a classic picture. Why is this important? Well, the nasociliary nerve is normally the nerve that innervates the surface of the eye. So if someone has nasociliary nerve involvement, then we need to look at the eye. How are we going to look at the eye? We're going to look at the eye with a cobalt blue light and fluorescein, and here we have a classic ulcer on the surface of the eye caused by the shingles virus. Why is this important? Well, this can affect vision and cause long-term scarring, so these patients need followed up by ophthalmology, and not only do they need oral acyclovir, they also need topical acyclovir eye drops. So hand, foot and mouth disease, although it's not really, it's a disease might be the wrong word, an illness, but it is caused by Coxsackie virus or enterovirus, two most common causes. So there's more than one cause. It's very, very common in childhood, goes through nurseries and young preschool children, etc., like wildfire. Classically, and this is where it gets its name, the lesions will be on the hands, the sole of the feet, and in the mouth. More often than not, the lesions actually come up the buttocks and the back of the legs, and that's often where it's worst, around the nappy area. Sometimes all you see is a couple of small red spots on the hands, so often it's not that easy to diagnose. It's a benign illness, very, very rarely cause any problems. Starts as macules and, a bit like chickenpox, develops into vesicles and blisters. It's not itchy in children, although it is in adults, and complications are very, very rare, but obviously there have been cases of viral meningitis and encephalitis, perhaps most commonly in those with illnesses predisposing to this, like the immunocompromised. But as a rule, it's something you can easily reassure parents about. Very similar with slapped cheek. It is in children a very benign illness. Predominantly starts with a very low-grade fever, a bit of a headache, just generally unwell. As the fever settles and the child is actually becoming systemically better, that is when the rash appears. Gets its name because of the redness of the cheeks. And obviously this little boy, you can see he's got the redness of his cheeks, and also you can see he looks quite happy. He's happy because he's now longer feeling unwell. It's just his parents are fretting about the rash. They often develop a rash on the rest of their body, described as lacy. But as I said, once the fever's settled, the rash appears and they're no longer actually infectious. It's caused by erythrovirus, used to be called parvovirus B19 for those of us that are old enough to remember. It, to the child, is completely harmless. In pregnant women, it has been linked to miscarriage, so often these women will get a scan if they've been exposed to it, sort of 6 weeks afterwards. But even these problems are fairly rare, and it's a condition you can fairly easily diagnose on the basis of history and the child's presentation. Roseola, but not that dissimilar. Fever for a few days caused by human herpes virus 6. Fever can cause fever reaching 40 degrees, accompanied with a sore throat. Quite often have lymph nodes up in their neck as well. Doesn't usually develop on the face, although you can see in this child here that the lesions do appear on the face. And the rash doesn't normally last more than 12 to 24 hours. Child, by the time you see them, is usually quite systemically well. So not that dissimilar to slapped cheek, although they usually will have had a fever and a sore throat preceding it, and the rash doesn't last terribly long. So that's all I'm going to talk about in this talk. Thank you very much for joining me. A couple of things I'll add. Remember that the most important thing in your diagnosis is not looking at the rash, but looking at the child as a whole. One thing I often say to parents is, if they didn't have the rash, would you be concerned about them? And a good proportion of the time it's no. I often use the same with fever as well. If a child's got a fever and not particularly otherwise unwell, and I say to mum, look, if they didn't have the fever, would you be worried about them? Or if you hadn't checked their temperature, would you be worried about them? And I find that's quite a good way of reassuring parents. So remember your history taking. Remember to get a good history of what's gone on with the child, and look at the child as a whole and not just at the rash. We are GPs, we try and be holistic, we perhaps don't always manage, particularly when we're rushed and busy, but I hope you found that useful, and I will be back very shortly with the next talk. And you should view these talks 1A and 1B as one whole talk, but I think in terms of making them digestible quantities of information, it's good to divide it into two. So next time we'll be covering scarlet fever, measles, and a few others. So I will look forward to seeing you soon. Thank you very much. Bye bye.